Hypertension Awareness Series Episode 19. Good morning. Today we learn about stepwise pharmacologic treatment of hypertension. I will discuss guideline-based initiation and combination therapy. Please note this is a technical presentation for those managing hypertension, our nurses, clinicians, and medical officers. And I will focus on guideline-directed therapy, drug combinations, and stepwise escalation in the treatment of hypertension. I start with the core principles, and these are the game changers. One of the key principle number one is start with dual therapy from the word go. Monotherapy is the exception, not the rule. From the ESC guidelines, initial two-drug combination from the word go. The AHA guidelines, dual therapy from the word go, BP over 140/90, and even in our Kenyan guidelines, dual therapy from the word go. Monotherapy is the exception, not the rule. Dual therapy leads to faster control, better outcomes, and less inertia. Principle number two, use fixed dose combination, single pill combination when available. This leads to better adherence, faster BP control, and improved long-term outcome. Start low, combine early, and titrate smartly. Before you start drugs, you need to confirm the diagnosis with proper BP technique, assess the cardiovascular risk and the organ damage. Don't just focus the BP. A reminder from what we covered in our last episode, when do you start drug therapy? From the ESC guidelines, the cutoff is BP of 140/90. You treat all of them. The AHA guidelines start at lower cutoffs, BP of more than 130/80. Kenyan guidelines, we are more like the ESC cutoff from BP over 140/90. But the key thing is individualized care. So what are the first line classes of drugs that you can use? Class number one, ACE inhibitors, example of enalapril, lisinopril, palidopril. The second class in the first line drugs are your ARBs, losartan, valsartan, telmisartan. Class number three, calcium channel blockers, e.g. amlodipine, long-acting nifedipine. Then class number four is thiazide and thiazide-like diuretics, e.g. idapamide, chlorothalidone, and HCTZ, hydrochlorothiazide. So let's now move to the stepwise pharmacologic treatment of hypertension. Step one, the initial therapy. Once you decide your patients need treatment, BP is over 140/90, you start with low dose two-drug combination, preferably single pill combination. And this is a major shift from previous guidelines. Now we always start with dual therapy. What are your options? Calcium channel blocker plus thiazide or thiazide-like diuretic. The other option, ACE/ARB plus a CCB. The third option is ACE/ARB plus a thiazide-like diuretic. Note, you never combine ACEs and ARBs. A special note in the black population. Calcium channel blockers and thiazide or thiazide-like diuretics are particularly effective in blacks. This is because hypertension in blacks is more of low renin physiology and salt sensitive or fluid dependent. So hypertension in blacks responds better to calcium channel blockers, the vasodilation, and volume control with diuretics. And this was confirmed by the Creole study, which was conducted in sub-Saharan Africa and compared amlodipine HCTZ against amlodipine palidopril against palidopril HCTZ. And the trial concluded that in this population, in black sub-Saharan Africa, using a long-acting calcium channel blocker, amlodipine, combined with a diuretic, which was HCTZ, or an SEE inhibitor, palidopril, is superior to ACE combined with a diuretic. So in our setup, amlodipine is easily available. HCTZ is easily available and cheap and has been shown by evidence that works well and controls BP well. Remember, monotherapy is the exception, not the rule. And most of it recommended only for mild hypertension, the frail elderly, or those with hypertension risk, symptomatic orthostatic hypertension. So step one, dual therapy. Step two, if your BP is not controlled, you escalate. You first check for adherence, lifestyle, are there any secondary causes? And then Once BP is not controlled on duotherapy, step 2, you can maximize the duotherapy, increase the dose. For example, if you started telmisartan HCTZ 40 12.5, you can increase to 80 12.5. So optimize the dose of the duotherapy, or you can move on to low dose triple therapy, ACE stroke ARB plus a CCB plus a thiazide. So low dose, optimize high dose duotherapy or low dose triple therapy. If your BP is not well controlled, you move to step 3. Step 3, now you have the triple therapy and optimize the doses. This can be ACE stroke ARB plus a CCB plus a diuretic, losartan, amlodipine, HCTZ, and optimize the dose. This controls most of the patient. If your BP is not controlled, you move to step 4. And this is where we start thinking of resistant hypertension and controlled BP on triple drugs, maximum doses including a thiazide. And before, you once again always confirm adherence, check the BP accuracy, review salt intake, check other medications that may interfere with BP, non-steroidal anti-inflammatory drugs, your steroids, screen for secondary causes. And then you add spironolactone, MRA. This is the first line add-on drug number 4. If the BP is not controlled, you can add your beta blockers, your alpha blockers, or central acting drugs. Remember, beta blockers can be added at any stage if there is a compelling indication. We will have an episode later to discuss resistant hypertension. So step 4, you are already on 4 drugs. And at this point, please consider referral to a physician. If your patient is already on 4 drugs and they are not well controlled, refer to a physician. So those are the principles. What happens in real world in the source limited setup? We know in our setup this may not always be available. So the key thing is use what is available, but apply the guidelines intelligently. Use what you have. Some common practical combinations that we can have even in our health centers: amlodipine and HCTZ. This is available and cheap as evidenced by the Creole study. You can use losartan and HCTZ. You can use amlodipine plus losartan. You can use enalapril with HCTZ. The key thing is duotherapy from the word go. These drugs are common even in the health center level. If I have enalapril, the BP is over 140/90. We have said the key principle is duotherapy from the word go. Start with what you have at low dose. We have also said the other key principle is fixed dose combinations. Sometimes in our health centers, we do not have these fixed dose combinations. So use the single pill combinations, but give as once a day dosing. So if you have enalapril available, you will give enalapril plus HCTZ. If I have losartan plus HCTZ, amlodipine plus HCTZ. The key thing is stress adherence, give the correct dosing, and if possible, once daily dosing. Use what is available but apply guidelines intelligently. Step 1, low dose duo combination therapy. Step 2, optimize your low dose duotherapy or go to low dose triple therapy. Then optimize your triple therapy in step 3. Step 4, you add your MRA or a beta blocker, alpha blocker, central acting agent, and refer at that point. The common mistake is staying on one drug too long, delayed escalation. The correct approach is review, adjust, and escalate, and refer appropriately. Cost is also an issue in our setup, so use affordable generics, and please refer if the BP is not well controlled. Refer appropriately. We can still control blood pressure well even in resource limited setups. Once daily dosing, affordable generics, use what is available, and dual combination from the word go. Stay tuned for our next episode where I discuss the common antihypertensives, their doses, and common side effects. As always, Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.